Hello, everybody, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me back again, Dr. Kenneth Milligan, an orthopedic surgeon from Monument Health. Glad you could come back. I didn't scare you off the last time. It was awesome. I'm glad you're here.
Yes,
Appreciate it. And joining you is Dr. David Woodard, also an orthopedic surgeon with Monument Health. Thanks for coming in, David. I know you kind of it seems like you got roped into this a little bit with Dr. Milligan.
A little last minute, but it'll be okay.
Perfect. Are you from here? Are you
from
local?
Brookings? From Brookings
okay.
Originally, so South Dakota, born and raised.
Yeah. Well, what led you to this right here?
I always had an interest in human anatomy, and I grew up playing a lot of sports, and so particularly the musculoskeletal system always had an interest for me. I think that the reason I decided to go into sports specifically is because I really enjoy taking care of young, healthy, active people and restoring the quality of life that they miss when they are unable to work or unable to do the things that bring them enjoyment in life the most, which are sports or other physical activities. And so being a sports surgeon, that enables me to get people either back to work or back to sport. And I just find it really fulfilling.
Oh, I suppose it would be. I mean, people that are in constant pain, can't move well, missing out on the things that they've loved. And if they can come and see both of you and, in a couple of weeks, they're back doing that stuff, it's got to feel fantastic. What kind of sports did you do, Doctor?
Yeah, so I played football, baseball, and I ran track in high school.
Okay.
None of it well, but I did participate. And so, I really just got a lot of enjoyment from the physical activities and continue to experience a lot of enjoyment from being active with my kids and my family. And so I think that's what just brings me the most enjoyment out of life is being active with my family. And so it's a really fulfilling job to be able to restore that for people. Excellent.
Well, the first time we talked with Dr. Milligan, we talked a lot about hip and knee kind of replacements, a little bit about what cartilage is, just kind of the mechanics of it a little bit. And when we were speaking with you before we started the podcast, you guys had wanted to talk about what you both refer to as the preservation of hip and knee. Can you explain that a little bit more, what you mean with that?
Yeah, so basically what preservation is probably most simply defined as preserving the cartilage that you have. And when it comes to knee, there's three main things that support knee cartilage, and it's mechanical alignment, or how straight the knee is. When that goes wrong, you're either bow-legged or knock-kneed. There's the integrity of the meniscus, which provides the shock absorption for the knee. And then there's the stability of the knee, which comes from the ligaments, ACL, PCL, MCL, LCL. So when any of those three things are off, the cartilage is what suffers.
Okay.
And so most broadly speaking, knee preservation is ensuring that all three of those components, the mechanical alignment, meniscal integrity, and knee stability, all are there to support cartilage health. And in order to either restore cartilage health or to optimize cartilage health, all of those three things have to be optimized. But then in addition, specifically, procedures are developed to actually replacing the cartilage itself, and a couple of different techniques involved in those as well.
So is preservation the same as like physical therapy, or is it much different?
I would put those in different categories, although certainly maintaining strength and range of motion is a vital part of chondral site or cartilage integrity, but I would put that more as one of the adjuncts to optimizing either current cartilage health or restoring cartilage health in the long term. I guess when we talk about knee preservation, we're specifically talk about procedures designed to keep the cartilage that you have or restore it.
And it's not, and it can be surgical or it can be therapy, correct?
Yeah. So I totally agree with Dr. Woodard. I think that when we talk about preservation, we're really talking about treating the non-arthritic hip or knee and trying to prevent that arthritis, especially that end-stage arthritis that results in needing a joint replacement. And so that it utilizes surgical techniques. It utilizes non-surgical techniques, and physical therapy is a pretty important part of that. kind of adjunct that we use in that treatment, but it also includes those surgical techniques. And really those surgical techniques, I think, are the newer techniques that have kind of really one of the new areas of medicine that have really been pioneered within the last, 15, 20 years.
Right.
To kind of treat this and prevent arthritis so that we're not necessarily having to replace your hip or knee.
Now, is this preservation for this cartilage, is this specifically for people who are starting to experience issues with the knee and hip? I mean, my hips are fine. I think my knees are fine. Do I need to worry about this preservation at all if everything feels all right?
I think when you talk about cartilage preservation, you're talking about, like Dr. Milligan alluded to, is chondral injury that has not reached to the point or the patient that needs a replacement. So that's arthroplasty and replacing the joint with metal and plastic parts.
Okay.
We're talking about cartilage injury in either the young or super active patient that isn't severe enough to warrant an entire joint replacement. So
is this a recent thing for you guys, this preservation? Or did it always, was it always like, well, it hurts, this is a problem, surgery?
Yeah, so for hip preservation in particular, it's a fairly new field. In fact, the original mechanical descriptions of one of the big kind of procedures that we perform was published in 2003. So this is a very burgeoning field.
Yeah.
I would say that, one of the important parts about preservation is that, and maybe not necessarily important, but just to kind of give some context to it, is that prior, when people would come in to a hip replacement doctor or knee replacement doctor, a lot of times people have the question, how did I get this arthritis?
Mm-hmm.
Is it genetic, or did I, was it from an injury? And especially with hips in particular, we would say it's idiopathic. We're not sure. And some patients, that wasn't necessarily the case. There were definitely mechanical things that predispose them to developing that arthritis at potentially an earlier age.
Okay.
And so instead of, hey, my hip hurts, and you go see the doctor and they tell you just to take some non-steroidal anti-inflammatories and maybe one day you'll need a replacement, patients are starting to come to physicians like me and Dr. Woodard to potentially see if we can diagnose something that may be going on that is a signal that their cartilage is starting to wear out, and we can intervene before it progresses to needing a hip or knee replacement.
We've heard the word arthritis quite a bit too in the conversation with both of you. You guys must deal. Is this probably the primary thing you deal with when it comes to hips and knees? Is arthritis? Is that what causes all of these problems generally?
So as a joint, so I do two things, or kind of wear two, and I do hip and knee replacements, and so I'm a fellowship trained joints doctor, but I also do hip preservation. And so for me in particular, I see a lot of arthritis. And so with the hip, patients do really well, but particularly with some knee things, especially for patients who are younger and active, a knee replacement doesn't necessarily provide the function that maybe very active young patients would want to have.
Right.
And so that's where I think these techniques, and maybe surgical techniques in particular, that Dr. Woodard is performing, are so valuable.
Yeah.
And that they allow patients to be very highly active and have a high function level of their joint without needing a knee replacement, which may not actually meet that same functional level as these preservation techniques.
So what's risk of sounding like Jerry Seinfeld? What's the deal with arthritis? Why does it affect so many people? And is it something that maybe somewhere down the line we're gonna finally get a handle on and be like, well, maybe we won't have this anymore? You think that's ever going to happen in your guys' field?
It's often that arthritis is just the normal wear and tear of
That's
a person's joint over the course of
Right.
several decades of life. However, as a sports surgeon, there are things that can accelerate the arthritis. When somebody has a ligamentous knee injury, you're on the fast track towards arthritis if that isn't addressed. If you have a meniscal injury that isn't repaired, or it can put you on the fast track. And similarly, people's biomechanics of their mechanical alignment of their lower extremity, typically you wear out both sides of your knee at about the same rate. However, if you're bow-legged or knock-kneed, you're going to wear out that loaded compartment much faster than the other side. So it is typically an end stage of life, or sixth or seventh decade of life event. However, injuries to the ligaments or the meniscus or mechanical alignment can significantly accelerate that. And so as a preservation surgeon, what I'm trying to do is I'm trying to intervene in the middle of that, and I'm trying to put you back on the 6th and 7th decade of life arthritis track instead of the 4th or 5th decade of life arthritis track. So
similarly, I think the hip is the same exact way. So, there are some developmental things, particularly with the hip, that arise actually quite young, and some of my patients are pediatric patients, and young adolescent patients, where they may have incomplete formation of their hip socket, which we kind of hear about, hip dysplasia. Yeah. And without proper coverage of that femoral head, you are predisposed to arthritis. And so that's actually a very, very common reason that females develop arthritis at an early age is dysplasia. There are some other types of developmental things that can arise. One is what we call femoral acetabular impingement, or cam deformity, and males typically are the ones who are more predisposed to developing that, and it's a little lesion or bump that can form on the femoral head. And as you do your normal activities of bending down, you actually end up pinching your labrum and the cartilage, and that ultimately will accelerate that wear and lead to arthritis. And that's actually one of the more common reasons that men develop early arthritis. And so you'll see that with loss of range of motion, or just people who naturally they kind of quote unquote say they have stiff hips. But what that could be is actually bony impingement, and it's not something you can necessarily stretch beyond.
Right. Okay.
But it's something that needs to be addressed. Growing
up, you always saw the commercials for arthritis in your hands. It was always the cream that you put in your hands to fix the arthritis. And I guess for the longest time I thought, well, that's the only place you get arthritis is in your hands. But it can be any joint in your body. Is that true? I mean, any place where you have a joint that can become arthritic.
Certainly, almost every joint in your body has cartilage, and so it can be worn out. And obviously, there are certain comorbidities that subject you to arthritis of one joint or over the other. Certainly, there's familial contributions to that. But I think when it comes to preserving your joint, what's important for people to know is that staying active is the most important thing you could do. Managing your weight is extremely important, and proper nutrition, exercise. But in addition...
Can I guess if not smoking is on this list too?
Yes, although it probably contributes to other pathology more.
It seems like every time I get to have a conversation with you guys, that will always come up as just stop smoking. It's not good for anything, right?
Yeah, and I think the last most important thing is if you do have pain in your anterior hip with deep squatting, or if you have joint line pain or catching, it's important to not ignore, because if you leave that alone for years at a time, it's possible that you get on a street that's a one-way street and towards arthroplasty. And so it's important when it comes to joint pain, and particularly when talking about preservation, that those early interventions can make a big difference in significant trajectory of that arthritis. And so if you're experiencing pain in your anterior hip with deep squatting, or joint line pain or catching, or feeling like your knee is unstable, don't ignore that for long periods of time, because it could be kind of a harbinger of really bad things to come.
Well, and maybe this is going to be a really hard question to answer, because everybody experiences pain, in their own way, right? So you say deep squatting, unstable knees. Sometimes you just have those pains that happen and they go away. When do you know I have to be serious about this?
Well, I think you alluded to it, and basically it's things that don't spontaneously self-resolve.
Oh, sure.
And so if
okay.
it's a consistent nag over the course of weeks or months, then it seems, I mean, it stands to logic, that's not going away.
Yeah.
And you're exactly right. Everybody experiences pain randomly throughout, especially as soon as you hit 30, it seems like it just
Right.
happens on a more frequent basis. But especially if it's a consistent nagging injury or pain, then that's something that needs to be addressed.
Okay. That absolutely makes total sense. So what else are things aside moving, exercise? It's just plays such a huge part in this. But it also, when I'm thinking about, okay, those are also the parts that hurt when you're exercising, right? So see your primary with stuff. That's where we start. And
Yes.
let them get you into you guys down the road.
Yeah, so I think if things aren't getting better, especially if they keep coming up and you hear that you don't have arthritis, I think that's when it's important to seek evaluation from a preservation specialist. There are a lot of x-ray views and special MRI sequences that we will do that your primary care or even a just standard kind of general orthopedist
Yeah.
may not do. And so even though you may have an x-ray that says that, everything looks good, an x-ray is only a two-dimensional image. And so if we actually maybe get that x-ray in a special view where you turn, we may see something that you can't necessarily see on those standard x-rays. And so if things aren't getting better, even if you've been told that, everything is fine, it may be worth coming in and seeing a joint preservation specialist. I will say, I've been practicing, this is going to be on my third year, and I have seen patients quite commonly over these last several years that have seen multitudes of people, and were told that, they didn't know what was wrong with them. And within getting a couple of special x-rays, it's quite evident that they have, pretty frank dysplasia with a very shallow socket and that's almost partially dislocated or something like that. Or they have other kinds of quite significant deformity of their hip. And it just takes, maybe getting those special views and seeing a specialist will really help with
I suppose
getting that workup.
Imaging, too, has made just your guys' jobs infinitely better. The better the imaging gets, the more detailed you guys can get, too, right? What do you, x-rays obviously have been around forever, changed the game for doctors like you guys. What is the best type of imaging to use for this? Is it an MRI? Is that the best way to get in to see what's happening with this?
I mean, I think there's a stepwise progression, right? So x-rays are really good screening tools for detecting bony abnormalities, but they don't pick up much of the soft tissue. And a lot of the things that we're talking about when it comes to preservation of the hip or the knee are soft tissue structures. Now, that being said, the bony alignment and deformity or proper formation does give you a big hint as to what's going on with the soft tissues. And so yes, you're right in the sense that, yes, MRI is the best test for revealing soft tissue injury, but it doesn't even just stop there. I mean, we can use CT and even put it through complex programming and perform a live movement of your hip and use that for preoperative planning and in determining whether or not you have bony impingement. And the program acts as if you are moving, and it'll tell you where the problem is.
Right.
And so there's a lot of tests that can and should be utilized when you're talking about these complex problems.
Yeah, so especially for the hip, we use really everything. The MRI does show us the soft tissue, and labral tears are one that probably people have heard about, or the labral tears in their hip in particular. So that does help us with seeing the cartilage. The labrum also does provide a biomechanical part to the hip, and so that's a useful information. With dysplasia, we also get ultrasounds as well to look and dynamically assess the hip to see how the ligaments are helping to stabilize the hip. We get CT scans with the three-dimensional reconstructions and can also do that kind of what we call collision detection, collision analysis to see where the hip may be impinging. So there are a lot of different imaging modalities and technology that has really changed in the last about 5 years, 5 to 10 years, that has really helped us be able to diagnose and find some of these problems. Is
there something even bigger on the horizon? Is there something that you guys are excited about, that you've been reading about or hearing about, that might even change the game even more? Or do you guys, is where we are right now kind of, we've plateaued a little bit until the next big leap happens?
Well, I think we're still making some improvements in cartilage restoration.
Okay.
In particular, I would say. And so that's being able to maybe address larger cartilage defects and doing that through minimally invasive techniques, especially in the hip. But even in the knee, I think that, that's still an area that there's some room to be improved upon. And I'm sure there's some technology that is coming around the corner that will probably help with that.
It's true that we are in the infancy when it comes to cartilage restoration, but it's also just a really fun and exciting time to be a part of the field then, because like Dr. Milligan alluded to, the procedures that we're performing on a relatively routine basis, some of them were not even described 20 years ago. And so we can provide a 25-year-old with hip pain an additional option besides hip arthroplasty or a giant open procedure. Now we can do Now we can address femoral acetabular impingement through 3 2-centimeter incisions on the hip and make a significant intervention in the long-term health of their hip. And when you talk about cartilage procedures, there are people in the NFL running around with cartilage procedures that didn't exist 20 years ago, or at least weren't mainstream. And so I think that it is truly just a super exciting time to be on the cutting edge of specifically cartilage restoration and joint preservation.
You bring up the NFL, and you'll see these guys that get knocked out for this, and the quickness in which they can return anymore is almost unbelievable, to a point where you're like, well, maybe a couple more weeks, my fantasy team can hold off for a little while. But it's truly been amazing to watch just through the decades on how you guys can take the cartilage, fix it, like you've said, and go in and replace the whole thing, and people can be almost completely back to where they used to be. It's fantastic, and I've said this before, that it's what I like in talking with you guys from Monument specifically is you guys have a passion for this, and that's exactly what you want in a doctor that you're going to see. So I tell people on the podcast, if you ever have these issues, if you ever have these conditions, you're in phenomenal hands here in Rapid City, because every single one of you guys I talk to, you love what you're doing, and that's plays such a huge part in this, I think, too. So Dr. Milligan, Dr. Woodard, thank you both for coming in and talking with me. Thank you. Anytime you guys want to dive into that whole area, I'm more than happy to talk about it if there's more stuff that comes around the bend. All right. Yeah. Thank you guys very much. I appreciate it.
Your time.
Thank you.